But do we see it going any deeper? Do you see it any deeper? So this is mainly kind of probably a surface, very superficially invasive candidal infection. But you can get infections with other organisms, usually not in the esophagus, but other areas that invade into blood vessels. And that's angioinvasion. This looks like a very superficially invasive process. So let's see if we can knock out our questions. So we talked about the inflammation. Does this look acute or chronic? Did you guys look at these inflammatory cells? So acute, what kind of inflammatory cell would you say acute? Neutrophils. Do you see any of those? What kind do you see in chronic? Lymphocytes and plasma cells. And you can see occasional eosinophils here and there, and those are kind of in between. They're not really acute, not really chronic. But so largely this is a chronic process, right? And we saw the organisms, so our diagnosis is Candida with this kind of superficial early invasion. Yes?
Would you call that epithelium dysplastic?
No. Okay, so and that's a good question. So, we do have some cytologic atypia, meaning that these look a little revved up. They've got little nucleoli. So you can see that in a dysplastic clonal process, or you can see it in a reactive process. So things that we use to help us realize that this is a reactive process is that we have inflammation with infection. And see how they're kind of the same, the nuclei, they're very smooth and round, and they look like each other. Mm-hmm. Each guy looks like his neighbor. And then see how there's lots of good space in between them. They still have plenty of cytoplasm. So when you become dysplastic, you get really hyperchromatic dark, and you get bigger, you get irregular, and you start overlapping your neighbor, and you lose cytoplasm. Your nuclear to cytoplasmic ratio increases. But that's a really good question, because as you noted, these look the same kind of all the way up, so they're kind of reactive all the way through the remaining thickness of the squamous mucosa. But this would be a reactive atypia. Any other questions on this? Okay, okay. So, what would predispose someone to have this infection? So Candida's kind of, it's around everywhere, right? It's everywhere, it's ubiquitous. But what would predispose someone to actually develop an infection with it? Immunosuppression, immunocompromised, right. So anybody on any kind of chemotherapy, immunosuppressive therapy, like a transplant patient, the very young, the very old, right? Neonates, elderly, okay. What are the signs and symptoms? So remember, a symptom is something the patient tells you, and a sign is something you actually see. So what would symptoms, how would this patient, what would they tell you? Yeah, it kind of hurts, my throat hurts, it hurts to swallow, it's uncomfortable, right? What would a sign be? Right, so if you're the endoscopist and you look in there, you're going to see these white plaques or patches kind of scattered throughout the esophagus. And so that's pretty much the only sign that we would have. And then how would you treat this? How would this patient be treated? Right, with an antifungal, right. Okay, good job. These guys here, some of this, some of this, yes, in every esophageal biopsy, you do see, because let's see if we have any existing. This is kind of a little papilla that goes up and they get squeezed out sometimes during the process. So these are artifact, because you don't see a collection of them like in a fresh hemorrhage. But you could, if you had a severe enough infection, you could have fresh hemorrhage. Okay, any other questions on this case? Okay, let's go to the next one.